Ladies and gentlemen, and welcome to this 22nd ERA webinar focusing on management of obesity and kidney transplant candidates and recipients. I'm delighted to introduce a very distinguished panel for this afternoon. First of all, we have Professor Evi Nagler talking about obesity and introducing the recent guidelines developed by the DESCaRTES group. We also have Ilaria Gandolfini, a consultant nephrologist in Italy, and Mr. Stephen O'Neill, a consultant transplant surgeon in Belfast, who are involved in the development of guidelines and will be the panelists discussing some of the data and the comments and the recommendations produced by the group. My name is Gabriel Oniscu. I'm a transplant surgeon in Edinburgh and vice chair of DESCaRTES, and I had the privilege of leading the group that was involved in the development of these guidelines. I'm also delighted to let you know that the participation in this webinar has been awarded 1 European credit for continuous medical education, and this is an exclusive benefit for ERA members. Traditionally with webinars, you will have ability to ask questions in the Q&A button using the Q&A button at the bottom, and we look forward to an interactive discussion on this very challenging and important topic in transplantation. And with that introduction, it is my pleasure to give the floor to Evi, who will present the main results of the guidelines. Evi, over to you.
Thank you, Gabriel. Yes. Okay, everyone can see my slides. Yes, perfect. So thank you very much for the opportunity of presenting this DESCaRTES guideline on obesity and kidney transplantation here on this floor. I'll start with my conflict of interest list. It's a very short one, other than obviously I've been involved in the development of this guideline. Before we start, I directly want to take you into a case history that we discussed during our transplant meeting a couple of weeks ago. It's about Jack, who's a 51-year-old man who's been on dialysis for a couple of months, has got type 2 diabetes, long-standing hypertension, and left ventricular hypertrophy. And he's been assessed for transplant and deemed suitable, other than his BMI being 36.5 kilograms per meter square. And so my first question to you is, and we'll put this in the poll, would you waitlist this man? And there's four possible answers. 1, yes, we don't have a BMI cutoff for waitlisting. 2, yes, our upper limit for waitlisting is 40, so he's well below that. No, our upper limit for waitlisting is 35 kilograms per meter square. He needs to lose weight first. Or 4, are you mad? Our surgeons won't definitely operate on him unless his BMI is below 30. So we'll wait a couple of seconds for you to think about your answer and submit it to the poll. And once you're all ready, we'll get the results up on the screen. Right. So that's interesting, yeah? Couple of different answers, and that's exactly similar to what we found in a survey held a couple of years ago, which suggested that transplant centers do seem to have very different cutoffs for active waitlisting, with some not defining any cutoff at all and others applying a fairly strict cutoff of 30 kilograms per meter square for active waitlisting. But the first study looking at obesity as a risk factor for transplantation and fueling this idea of having a dichotomous cutoff dates back to 1990 in Pittsburgh in the US, where they compared 50 obese kidney transplant recipients with 46 non-obese recipients for a number of outcomes. And what they found was that amongst those with BMIs above 30, death happened more frequently in the perioperative period. They had to be reintubated more frequently. They suffered wound complications. The surgical procedure lasted about an hour longer. They developed new onset diabetes more readily, and that ultimately translated into poorer patient and graft survival at 2 years. But the question now becomes whether such a dichotomous cutoff for waitlisting based on those data is still valid in light of what we know about obesity today, and if such a threshold exists, where that should lie. And that's a particularly difficult question to answer, partly because the question is threefold. And the first of that is whether BMI is the best or even a good measure for defining obesity as a risk factor in dialysis or transplant populations. Because we know that in the general population, BMI, as it increases, it's correlated well with increased cardiovascular risk. But if we start looking at the dialysis population, then that image quickly blurs, because we're all aware of something called the obesity paradox, which is the observation that people with higher BMIs tend to do better on dialysis rather than worse. And some have blamed the BMI as being at the root of all evil here, because one, it doesn't differentiate between fat and lean mass, and two, it doesn't mirror fat distribution, with abdominal adiposity being the more strongly correlated with chronic disease. And so in response to that criticism, a number of other measures have been used and developed, such as waist circumference or waist to hip ratio, which in a general population are all positively correlated with risk of death, even when adjusted for BMI. And so does that mean we and does that hold for the dialysis population? Yes, it does, or at least it seems to. And this is one of the only comparative studies which comes from the Calabrian Registry of Dialysis and Transplantation, and in which they indeed found that higher waist circumference was associated with poorer outcomes in multivariable analysis and when adjusted for BMI. So we ditched the BMI and switched to one of these other measures. Well, the thing is that it may not necessarily be a problem of the BMI per se, but rather a result of the methods that are used to analyze the data, because invariably in these studies, researchers assume a linear relation between the BMI and outcome and death and graft survival. And that is fundamentally untrue. And where for waist circumference, that relationship assumes a flattened J-curve, the one for BMI is a U-curve. And that means if you do a linear regression, that invalidates any kind of dichotomous association that you find with BMI and outcome, and it even inverts that relationship as the left-hand side of the curve becomes steeper. And second of all, normal weight is being defined as a BMI between 18.5 and 25. Now we know that even in the general population, a BMI of 18.6 incurs worse outcomes. You can imagine what that means for a dialysis population with chronic disease and comorbidity. What I'm getting at is that the inverse relationship that you sometimes see, especially in dichotomous analysis of the BMI and outcome, that it may not necessarily be the result of a biological paradox, but rather the consequence of cataloging people with BMIs between 18.5 and 20 as having normal weights. A number of other measures, as I said, have been developed, and they all have their own limitations, amongst which is lack of standardization in measurements, high inter-rater variability, sensitivity to abdominal distension, and what's important in our population, also sensitivity to polycystosis. And so that we translated that into the following statement, suggesting measuring waist circumference or waist hip ratio in addition to the body mass index in patients with end-stage kidney disease living with obesity who are being assessed for transplantation. But we don't really attach any consequence to that measurement. We need to acknowledge that virtually all of these studies that have looked at BMI as risk, that have looked at obesity as a risk factor for transplantation, have used BMI as a proxy for that. And most transplant centers do have a dichotomous cutoff based on the value of the BMI. And so with all the limitations of BMI in our thoughts, the next question becomes, what is the influence of increasing BMI on the outcome post-transplantation? There's been a number of systematic reviews devoted to that, and I'm showing you the largest of the series here, which includes 56 cohort studies and over 200,000 incident kidney transplant recipients. And what they compared was a number of outcomes between those with a BMI above 30 at the time of transplant versus those with a BMI below transplant. And only 16 of these studies could be put into meta-analysis, but when that was done, it appeared that the risk of death was about 50% higher for those who had a BMI above 30 at the time of transplant. But the problem is only 5 of those studies adjusted their estimates for comorbidities. And when you put those into meta-analysis, then that effect disappears, leaving no difference between the groups. And that's what partially explains that obesity paradox. If you look at the effect of a risk factor such as obesity and an outcome such as death in a subgroup of the general population that has some sort of chronic disease, and that can be CKD, can be diabetes, you will always find an association between BMI or obesity and death, even if in reality that effect is not there. And that's because another, perhaps more important risk factor affects both the weight and the risk of death, and the BMI captures part of that effect in its measurements. A similar picture is seen for graft survival with systematically poorer outcomes at 3 years when you meta-analyze unadjusted estimates, but an effect disappearing once you only meta-analyze those that are adjusted for comorbidity. And so the story continues with a 10% absolute increased unadjusted risk for delayed graft function, 4% increased risk of acute rejection, a surgical procedure that takes about 45 minutes longer to perform, a length of hospital stay that's about 2.3 days longer for those who have a BMI above 30 at the time of transplant versus those below. The risk of wound infection is about triple that for people with lower BMIs, and the risk of post-transplant diabetes almost doubles for the ones with BMIs above 30 at the time of transplant. So what does that mean? Well, in worst case scenario, it means that, leaving all confounding in these surgical outcomes aside, that perhaps unsurprisingly, people with BMIs above 30 at the time of transplant do suffer operative complications more frequently. But that doesn't translate into poor patient or graft survival after transplant. And that's corroborated by another systematic review. It looks at BMI in a slightly more continuous fashion, but unfortunately it doesn't tell us anything at all really about the group of people who've got a BMI above 35, let alone those with BMIs above 40, because there's very, very few people in there, and that's reflected by a widening confidence interval, but even that is extrapolation of the data because they're really not there. And so this was translated into the following statement, suggesting to accept people with end-stage kidney disease and a BMI of 30 to 34 for kidney transplantation if they're otherwise considered suitable, but that there are insufficient data to make a recommendation for the higher BMI categories. And that's based on the comparison of outcomes after transplant between those with higher versus lower BMIs. And obviously, from a utilitarian principle, that's an important or even an essential comparison to make. But from the individual perspective, it's definitely not the only, let alone the most important factor to look at, because otherwise we'd only be transplanting the youngest and the fittest, and we don't do that. So from the individual point of view, what's perhaps more important is the comparison between being transplanted or remaining on dialysis for a particular level of BMI. And here the largest studies comes from, again, perhaps unsurprisingly, the US, which included over 200,000 kidney transplant recipients and looked at survival 1 year after transplant for the different BMI bands. And what you see is that they don't seem to lose their survival benefits as the BMI goes up, with that remaining in place even if as the BMI increases over 35 and even over 40. And this time there's over 16,000 people, I think, in those who have a BMI above 35, and over 9,000 in the BMI category of 40 and above. But we know it's always tricky to transport data from the US to a European setting, knowing how dismal their survival on dialysis is. And so this is a study that was done in the UK, which included over 13,000 people. And again, what you see is that survival is clearly better for all BMI categories in comparison with remaining on the waiting list. The only problem there is that, again, for those higher BMI categories, there's very few people in there. And that's reflected by widening confidence intervals, as you see on the right-hand side of the panel. So where does that leave us? At this point in time, there's no good evidence that people lose their survival benefit as the BMI increases. Now, that's not the same as to say that they retain, that there's good evidence that they retain their survival benefit. And obviously all what we're looking at is survival here. We're not considering any of the other outcomes that we do find important after transplant, quality of life, and all these other outcomes. So that was translated in a discretionary statement that we likely think that transplantation, either from deceased or live donor, is likely the better treatment for people with BMIs between 30 and 39 who are otherwise considered suitable for transplant, and that delaying waitlisting or transplantation is likely better not done, again, for people with BMIs within these categories. Because we felt it was difficult to justify withholding a treatment for a certain subgroup of people that is likely to benefit from that without evidence for the contrary, and based on a variable that doesn't seem to reflect obesity as a risk factor for transplantation in the first place very well. That's not to say we shouldn't aim for obese people to lose their excess weight, either via medical weight management programs or possibly via bariatric surgery. And I'll take you back to our initial case of Jack, and I'll put the following question for you. What would your strategy be? Would you, one, waitlist? Would you waitlist and include him in a medical weight management program? Would you include him in a weight management program waitlist and only waitlist when the target weight is achieved? Or would you immediately refer him to bariatric surgery and waitlist when he recovered from the surgical procedure? Or would you send him for bariatric surgery and wait until the target weight is achieved? And again, we'll give you some time to answer that question. Okay, variable answers. So most people would waitlist and include him in a weight management program, but there would be people who would wait until target weight is achieved. Okay. Oops. Yeah, so what can we expect from a weight management program in dialysis patients? There's really only one comparative study, which was set in London's King's College, where at least until 2008, they applied a cutoff of 30 for active waitlisting. And so what they did was they, in a non-randomized experimental study, they offered about 60 kidney transplant candidates who were otherwise considered suitable for transplant a multidisciplinary weight management program, which included a kidney-specific low-fat, low-calorie diet, an exercise program, and a standard dose of orlistat, which is a locally active gastrointestinal lipase inhibitor causing fat malabsorption. And what you can see is that to start with, 2/3 of people declined to participate, and of those that did participate, a quarter dropped out before the study was finished. Now, those that did continue the study did manage to lose some weight, about 6 to 7 kilograms, and they maintained that weight loss over a 2-year period. But on the whole, what you see is that for about half of the people that just doesn't work. And what's perhaps more worrying is that you don't actually know which part of the treatment that was most effective here. And obviously we're quite worried about orlistat in this respect, because as it induces fat malabsorption, it may increase oxalate resorption, and that may cause hyperoxalosis, hyperoxaluria, which in its turn may cause parenchymal inflammation, nephrocalcinosis, and progression to end-stage kidney disease, which in combination with possible interaction with immunosuppressants after transplant doesn't make it a particularly attractive or appealing treatment possibility. And then there's bariatric surgery. In the general population, classic criteria usually apply, being a BMI above 40 or above 35 with at least one major obesity-related comorbidity that's expected to improve with weight loss. For those of you who are not very familiar with metabolic, with bariatric surgery, there's broadly four metabolic surgical procedures: the vertical sleeve gastrectomy, Roux-en-Y gastric bypass, adjustable gastric banding, and the biliopancreatic diversion with duodenal switch. All of these can be performed laparoscopically or via open surgery and are either restrictive or malabsorptive or a combination of both. So there's a vertical gastrectomy in which about 70 to 80% of the stomach is cut along the great curvature to create a tubular remnant, which can't expand because it lacks the fundus, and that creates a high pressure chamber in which the stomach is emptied quickly into the duodenum, and food is passed early. The second is a Roux-en-Y gastric bypass. That's a slightly more complicated construction where the stomach is cut into a 15 to 30 milliliter pouch. Then subsequently, it leaves a stomach remnant that doesn't come into direct contact with food. Then the jejunum is cut midway, with the distal proportion being lifted up to the gastric pouch so that food passes directly into the distal jejunum and bypasses the duodenum and the proximal jejunum. And then you're left with a biliopancreatic loop, which drains all of the gastric fluids, the pancreatic fluids, the biliary fluids directly into the distal jejunum, such that absorption and digestion happens thereafter. The longer that biliopancreatic loop, the higher the risk of enteric oxaluria and reduced absorption of immunosuppressants. Then there's the adjustable gastric band, which is a silicone band that is placed around the stomach and is inflated through injection of physiologic fluid into a subcutaneous port that allows you to adjust the diameter. It creates a small 30 milliliter pouch with limited passage of food to the rest of the stomach. It's gradually being abandoned due to higher late-term complications such as herniation of the band through the gastric wall. And then there's finally the biliopancreatic diversion with duodenal switch, which is more or less a combination of the vertical sleeve gastrectomy and a duodenal ileostomy, which causes food to bypass the duodenum and the jejunum. Again, it's a procedure that's gradually, or that has been abandoned in recent years because of the severe malnutrition that it causes. It shouldn't surprise, I think, that again, there's very limited comparative studies. There's few studies, they're never head-to-head, and they don't clearly and can't clearly show, due to small numbers and short follow-up, that the weight loss that actually occurs with all of these procedures, that translates into better patient and graft survival. And obviously these procedures come with a risk of post-operative complications in what is an inherently immunocompromised patient population, and those risks aren't very well characterized at the moment. We looked at 22 case series, which included 1,400 patients, and there about 1.5 to 2% died in the first 45 days after the procedure, and 7% developed major complications such as leaks, peritonitis, etc. And that may or may not seem reasonable, but it needs to be weighed against very uncertain effects on the long-term outcome after transplantation. If bariatric surgery is considered, then there's a number of reasons, despite direct head-to-head comparisons, a number of reasons to prefer sleeve gastrectomy over other types of surgical procedures. And that's because although the weight loss that is achieved with sleeve gastrectomy is less pronounced than for Roux-en-Y gastric bypass, for example, you do get about a 6 to 17 point drop in BMI, and that's enough to facilitate transplantation, for one. And two, there seems to be no influence on absorption of immunosuppressant medications. There seems to be no influence on absorption of oxalate, or at least much less influence. Operative times are shorter. There seems to be lower estimated blood loss, and hospital stay seems shorter as well. And that's translated into these statements. We recommend encouraging kidney transplant candidates living with obesity to lose weight and have their nutritional status supervised by a multidisciplinary weight management team. We suggest considering, so that's a very discretionary statement, we suggest considering bariatric surgery in kidney transplant candidates with a BMI above 40 and in those with a BMI above 35 with at least one major obesity-related condition that can be improved by weight loss. And if bariatric surgery is considered, then we suggest laparoscopic sleeve gastrectomy over other forms of bariatric surgery. All of these are discretionary statements based on low-level evidence indicating that individual decision-making is definitely the order of the day. And then finally, there's a question of timing. When should these procedures be performed? Should we do this before or after transplant, especially if you're considering a live kidney donor? Or what happens if the weight increases after transplant? Well, again, there's only one comparative study that looked at 21 kidney transplant recipients who received bariatric surgery after their transplant and compared them with 43 candidates who received it before they were transplanted. And as you can see, weight loss was similar in both groups, but again, this is a retrospective study with very different baseline characteristics, and those in the post-transplant bariatric surgery group gaining weight after transplantation. So difficult comparison to make. A second comparison was with those matched weight matched controls that didn't receive bariatric surgery at the time of transplant. And what you see here is that all-cause allograft failure or mortality after transplant seemed to be lower for those who had received bariatric surgery after transplant, indicating that it may be a feasible strategy also after transplantation that doesn't incur unacceptable post-operative complications when done after transplantation. And that is translated in the following final statements, suggesting to consider bariatric surgery in kidney transplant recipients in those with BMI above 40 and those with BMI above 35 with at least one major obesity-related condition that can be improved by weight loss. And again, although there's no comparative studies between the different techniques, there's here similar reasons for preferring sleeve gastrectomy over other forms of bariatric surgery as the ones we talked about before. And then finally, in an advice for clinical practice, we consider it reasonable to consider bariatric surgery only after appropriate non-surgical measures have been tried but failed to achieve an adequate and clinical beneficial weight loss. And obviously that will have to be, reimbursement policies will need to be checked, and likely strategies will be variable across different healthcare systems as large differences for reimbursement policies for bariatric surgery may exist. And that brings me to the end of my presentation, and I look forward to a very interesting discussion. Thank you very much for the attention.
Evi, thank you very much for this tour de force of a couple of years of work in the Guidelines group, which was thoroughly enjoyable. So to give you a bit of a rest, we'll go now to Ilaria and Stephen, who are part of the group. So any initial comments, any things you want to add? Ilaria first and then Stephen.
Hi. My first comment is on the, so as Evi said, we have to distinguish between what is an obese and non-obese kidney transplant candidates, and what is an obese on dialysis and on transplantation, and what is the benefit of the person being transplanted or not. And so we have to take into account a lot of things. We have to try to share this decision with the patients, informing the patient that an obese patient had an increased risk of complication after transplantation. And but if the patient is very well informed and consent to the transplant, especially in the context of, for example, of a living donation, we should make this decision in a whole context. So we didn't talk about the different donation. Of course, if he has a living donor, it's different from a standard criteria, disease donor or extended criteria donor. The outcome also in obese patient is different. And even if we have limited data on the 35 to 40 of BMI, the scarce data we have so far are encouraging the transplantation also in these patients. And another thing is that the only recommendation we did in our guidelines is apparently on the multidisciplinary weight loss, and we saw that it has not really a strong effect. However, it is hard to not to say to the patient, try to lose weight and eat properly, do exercise. Also, I mean, from decreasing the cardiovascular risk in total. And however, this should probably go along with the wait list, if not otherwise contraindicated. And for the surgical procedure, we have to also to admit that not all centers are very expert on this. So we should put the patient into the, give the patient all the information, and maybe also to send the patient to maybe an expert clinic in case of bariatric surgery. And it would be ideal to share maybe also in Europe some highly expertized center for bariatric surgery to make this decision properly. And the last thing is that we start from the thing that BMI is not a good cutoff for the obesity, and then we are talking about everything based on the BMI. So I suggest all the centers, when you are waitlisting a patient, you are visiting a patient, also not to just take the weight and height, but maybe just to take a meter and measure the waist circumference. This is what we could do retrospectively, because everybody has a height, has a weight of this patient, but maybe it will be good to start in a different way. Or I would also maybe try to measure the waist circumference based on some CT scan that we had before, maybe, don't know. But we should change our mind also in approaching these patients.
Thank you, Ilaria. Now let's hear the surgical view from Stephen. So is there anything you want to add or you do differently?
Yeah, no, I just want to start off with saying thanks to Evi and Ilaria for some great points there and fantastic talk. I suppose the main thing from my perspective is to have an individualized approach. We're obviously trying to create a guideline, which is helpful for clinicians, but it's really important to take into consideration the whole picture. And I think some of the questions that have appeared on the chat allude to that. In terms of complications being greater, that's it goes without saying. But I would argue that someone like Jack, who you presented, would be listed without debate at our transplant NTM.
Thank you, Stephen. So a question to all three of you, really. So despite the fallacies of BMI, as Ilaria pointed out, we are still using it as the most common measure. We also know that within the same centers, even nephrologists and surgeons don't agree on what is the right cutoff. So this is quite confusing for the patients. So what do we need to do to unify the views and have a, not necessarily common front, but a clear approach that we can put to the patients out there? Evi, shall we start with you?
Well, I think given all of the limitations that we've talked about when using BMI, and as I pointed out and Ilaria confirmed, is that there's no clear correlation with long-term outcomes. I think we need to move away from this idea of using BMI at all as a discriminator. We need to start measuring other proxies for obesity and assessing to what extent that has an influence on outcome, and whether these are more amenable to treatment, for example. I think with the knowledge that it's a very poor marker for obesity, especially in that population, and even if you use it with the knowledge that there's no clear association with outcome or with poorer outcomes, it's very difficult for me to keep on justifying having that cutoff. So the first thing would be to move away from it, to let it go, to start transplanting, or to start at least waitlisting people with disrespecting this BMI, but looking at the entire picture of nutritional status and physical abilities, etc., and assessing what such decision making has on transplant outcomes, and then reassess once we gathered those data. I think you run into equity problems if you start discriminating people based on a marker like that. That's basically shown to be rubbish in discriminating the good, the bad, and the ugly.
Stephen, what is your view as a surgeon on that, or would you have a different opinion?
Yeah, I suppose you can't entirely open the floodgates, because you could end up with some pretty poor outcomes. But I suppose when you have people that are functionally fit, good exercise tolerance, no severe, cardiovascular complications to go with their obesity, then I think it's reasonable to take these patients on. We have to consider the consequences of remaining on dialysis, which is kind of underappreciated, I think, in various discussions.
Okay, so that takes me to a nice question that was raised by Arzu Velioglu on the question. So in that case, how do we move away to this, and whether we should consider a different approach? And his question is, what is the impact of low muscle mass and sarcopenia, regardless of BMI, on post-transplant graft and patient survival? Should we do that? Should we actually assess sarcopenia before transplant? Ilaria, what do you think?
I would think so, yeah. There are now papers going out from, especially from the Johns Hopkins University, that are taking into account the waist circumference at the CT scan and measuring also the lean mass. And they are finding, of course, a correlation between waist circumference, so the fat mass, and the survival, and on the contrary, so with the least, the worst combination, low lean mass and high fat. I think we should do I don't think in all the centers we can have a dietitian or someone that is always like do frail tests and assessing the limb mass, but ideally I would do it. And I think it's a very good combination to measure the risk and the complication post-transplant of this patient. And so, yeah.
I mean, this is obviously straying into frailty and a slightly different combination altogether, but I think the question is more relating to sarcopenic obesity and how we deal with that. Evi, you mentioned there that one of the recommendations we made is that between 30 and 39 BMI, we suggest listing of what is otherwise described as an otherwise suitable patient. So my question to you first, and then to the rest of the panelists are, what do we mean by otherwise suitable? Is otherwise suitable in a BMI of 40 equal with otherwise suitable in a BMI of 30? Should we have the same definitions? In other words, how many comorbid conditions are too many? And how do we equate the weight of cardiovascular risk in someone who's heavier than someone else?
I think that's a very valid question and a particularly difficult one to answer, because in reality, it's as Stephen mentioned too, it's always a weighing of different risk factors, and at some point there's this subjective intuitive decision that is a weighed decision by the transplant team that says, well, considering all of these comorbidities, we think that chances for him or her to do well after transplant are too slim for us to go ahead with the procedure. But the problem is that there's no clear cutoffs for that. There'll be some patients in which you'll allow for quite a lot of pre-existent cardiovascular disease in the absence of other comorbid conditions, and others where it's a combination of a couple that will cause you to make this intuitive decision that enough is enough, or this is too much. But there's no clear models that help us determine what outcomes for people are dependent on 1, 2, 3 of these comorbid conditions and the degree of the comorbid condition. So even if what we surely lack is good prognostic models that are granulated enough to allow us to really reflect an individual patient's profile, and that doesn't exist. And so it will always come down to this intuitive weighing of comorbid conditions. And that's a problem in itself, because obviously that leaves a lot of room for subjectivity and different and variable decisions being made depending on the day and the mood of the people who are in the room.
Absolutely. And Stephen, you would know from the UK that in the ATOM study, we found clear differences in how this sort of things that Evi was talking about is interpreted. So with your research hat on, how do we design that study that Evi is talking about? How do we define that algorithm that allows us to be objective or truly objective based on patient data?
Yeah, well, I think it's really difficult, and it's one thing that we've struggled with. We've got a cohort of patients with a BMI of 40 plus that we've transplanted. What we don't have is a comparator cohort of people who've been listed and not transplanted. I think the comparator group of BMI 40 plus who've just remained on dialysis and aren't ever listed isn't going to be helpful. So I think it's really difficult, and I actually don't have an obvious answer to that, other than pooling resources and data from various areas to get sufficient numbers. It was disappointing to see from the UK study that I think only 66 patients with a BMI of 40 plus had been transplanted. I'm not sure what the group size was for those that had been listed and not transplanted. Perhaps Evi might recall that. But I think it's a difficult question, and it's a difficult area to have enough data to analyze.
Ilaria, your thoughts. I mean, obviously, some of the data that Evi's presented comes from Italy and fairly large registry analysis. What are your thoughts on this? How do you think we should approach it?
So I think that it's an individualized decision. First, taking into account all the pros and cons of transplanting or denying a transplant in these patients. And maybe like for a patient with BMI of 40, maybe we should inform him and let's make a test. I don't know for how long with the multidisciplinary team, admitting that it will be fairly unuseful, and then maybe asking him if he has the intention to undergo maybe also a bariatric surgery, and then balancing all the things. But it's hard after seeing all the data from the world not to wait list this patient. Of course, a BMI greater than 40 is hard to say that is otherwise suitable. I mean, it normally has diabetes, hypertension, it is connected with a lot of other things, but in rare cases, it could be a unique condition apart from CKD. So I think it's different from one patient to the other. And if I can, I would pose a question to the surgeons. Do you think that the surgical techniques like robotic or standard technique has a difference in giving them an option to these patients?
Steven, take that one, Gabby.
Well, so there is a bit of evidence for robotic surgery, and I think like much else that we discussed today, the evidence is fairly scarce, and I think, but it's growing, and I think it is a potential way of transplanting these patients. And I think you've unfortunately preempted my last question that I had to all of you to turn the ball across the net to all of you, is how do we design a study? But perhaps we'll come to that at the end, to try and understand if we were to move things forward, how we do that. Okay, so you're going to list the patient, or you consider some intervention. Evi talked about a number of interventions. So here's a question from the Q&A. Evi showed the weight management program in that study from Cohen and Al, and I think there was someone else from the US looking at Orlistat, but what is the role of the modern GLP-1 agonists in weight loss in this patient population? And obviously, there are certain advantages in terms of cardioprotection, malabsorption, et cetera, et cetera, et cetera. But what is the evidence for new ones out there, such as semaglutide and others?
I think I'm expecting some of the data will likely come out in the years to come, but at the moment that data is simply non-existent in that kidney transplant candidate population. So it's not been tested especially with the idea of facilitating weight loss and allowing weight listing. So that data is just not there.
But would you use it post-transplant?
I guess I would consider using it post-transplant, but again, based on data that we see in the general population and people with relatively good kidney functions. So I think it's definitely an option and a route to explore in the future, but at the moment, without any clinical and research data to support safety profiles in those patients. Not necessarily expecting large problems there, but without any clinical data to support that at the moment.
Okay. So that is not an option at the moment. So then I'll turn to Stephen and Ilaria, not necessarily particular in that order. We talked a little bit about bariatric surgery and its role. It's a small group at the top of the pyramid of interventions that we want to do. Shouldn't be seen in isolation. Stephen, bariatric surgery before or after transplant. So Evi suggested that between 30 and 39, you should otherwise list a suitable patient, but we should consider bariatric surgery. So what comes first, bariatric surgery or listing? What are the benefits of listing, suspending, or doing surgery and listing later? I guess what I'm getting at is the more you delay, there is an impact on the outcome of subsequent transplantation. So how do we define, first of all, the role, and secondly, the timing of intervention?
So we don't actually have any bariatric surgery services in Northern Ireland, so I don't have an algorithm in my head for what I would personally do. But I think, again, it comes back to an individualized approach. You know, is the patient at the low clearance stage with the GFR approaching 15? We've got some time before dialysis. Are they on dialysis? Do they have a live donor? Is there a shot at a preemptive transplant? What's their vascular access issues like? So I think it's not going to be a one size fits all.
Ilaria, you talked earlier on about perhaps referring patients to different centers. So here is Stephen's predicament. He doesn't have obesity surgery available in his own center. Should he refer the patients elsewhere for that intervention?
Maybe, as Stephen was saying, maybe we should act before the wait listing, maybe on a late stage of CKD, when also the patient could benefit from the loss of weight, and even in terms of diabetes, hypertension. And maybe in that setting, I would choose before the bariatric surgery and after the kidney transplantation. If a patient is, for example, coming to us with a living donor, I would choose before the living donation. And then in case the patient, because we have pros and cons. Before him on dialysis, the patient has a lot of limitation on fresh vegetables, fresh fruit. The patient cannot eat a lot of meat. So the most of the diet is based on carbohydrates. And even if we don't have a very good nutrition expert, the patients are often malnourished, and it's very hard to say eat properly and do some exercise, especially with an obese patient that is like 3 times a week on dialysis. It's very hard to say. And on the other hand, after transplant, he can have an increased body weight because of steroids and other factors. So, but it's like a kind of change in the habit. If he's not experience a lot of complication after transplant, after 6 to 9 months, maybe he can have the option, he can have the possibility to change his lifestyle. So I would choose like this.
Evi, I'll turn to you now. So is there any evidence that undertaking bariatric surgery and delaying listing and by default transplantation has a detrimental effect on the outcome?
No, but there's no evidence for the other side of the spectrum either. So that the data is just very limited. And I think I do see an opportunity for administrative data being used here, because what we definitely lack is a granularity in the data. What we lack is a good view on, for example, the evolution of people's weight on dialysis. And much of those data are likely to be able to be pulled from administrative data. The only problem remains is that you still don't have access to other measures of obesity, and that's I think is the biggest problem that we need to tackle. Because I think if even in those cases where you want to just look at the trajectories of people and what the influence of these different trajectories is, I think those may be able to be pulled from large administrative databases if we pull national databases together. So that may be something where international collaboration could prove some to be some solace to the problem.
Thank you. We've got a couple of minutes left, and obviously we covered quite a lot of ground. So the guidelines are good. They clearly suggest some improvements, but I think they raised a lot more questions. And what's quite evident from our discussion today that there are many known unknowns, but also many unknowns. So question quickly for all three of you for the next, in 1 minute each, what study would you design to address some of the challenges that we've done here? And it'll be nice because you can come up with 3 studies, then as Evi said, we'll do an international collaborative effort to answer those. So in no particular order, Ilaria, what will be your preferred question to answer here, and how would you do it?
So I would start from a simple study. So everybody at the time of weight, height, waist circumference, and like, for example, lean mass measurements, and then see what is going on.
Excellent. Evi.
I'd do the same, but I'd start much earlier on. I think one of the major issues is that we don't have common time points. The T0s differ for all of these comparative groups. So what would be interesting to see is what happens as people enter CKD stage 5 and have these measures that Ilaria was talking about, but have them repeatedly throughout the life cycle of the dialysis and then the transplant patients. And so to see whether you can discern patterns there. And take into account weight evolution as they pass through each stage of pre-dialysis, dialysis, transplant, and post-transplant.
Thank you. Stephen, what would you do?
Yeah, well, I suppose there's good ideas for prospective studies there. So maybe a retrospective idea is just, although BMI is imperfect, pooling those resources that we talked about to look at outcomes in the BMI 40 plus group versus those that were listed in the BMI 40 plus group that weren't transplanted.
What about bariatric surgery? How you would go about doing a study on that?
I think at the earliest possible stage, identifying patients and at that kind of low clearance clinic, considering some for bariatric surgery and others for just standard management. Whether that's suitable for a randomized trial, I'm not sure.
Okay, thank you very much to all. We don't have any more questions in the Q&A. We're approaching the end of the webinar, and it remains to thank, first of all, our guest speaker, Evi Nagler, for a fantastic presentation of the guidelines, and to Ilaria and Stephen for their expert comments. Goodbye from all of us, and hope you enjoyed this webinar. And it remains me to remind you that you're welcome to our next webinar on the 29th of March with the topic of low protein or low carbohydrate diet in diabetic kidney disease patients, organized by the European Renal Nutrition Working Group of ERA. And with that, thank you very much for your attention, and stay safe.
Bye.